All right, so good evening, colleagues. Welcome to this weekend's tutorial. It's a continuation of what we started last week. And today we're going to concentrate on renal replacement therapy. As usual, I want us to attempt these following questions, this case-based MCQ. If a 55-year-old male patient in ICU with septic shock develops AKI, acute kidney injury, with serum potassium rising to 6.8 millimole per liter and pulmonary edema despite diuretics use. Is hemodynamically unstable on low-dose vasopressors. Which modality of renal replacement therapy is most appropriate here? A,
Continuous
intermittent
replacement
dialysis, B, peritoneal dialysis, C, continuous renal replacement therapy, D, low efficiency daily dialysis, hemodiafiltration. Which one?
C.
C.
Correct. C, continuous renal replacement therapy. A 40-year-old post-operative patient develops severe hyperkalemia and metabolic acidosis. He is stable hemodynamically and alert. The ICU plans urgent dialysis for the hyperkalemia and metabolic acidosis. Which of the following is the preferred initial choice? A, continuous venovenous hemofiltration, B, intermittent hemodialysis, C, SLED, D, peritoneal dialysis, and E, hemodialysis with high blood flow rates.
B.
Sorry?
B.
B.
Am I hearing B or C?
B. Intermittent hemodialysis.
Okay. Do we agree with that, everybody? Anybody with another option? Okay, so B is correct. All right. A 65-year-old ICU patient on continuous renal replacement therapy for AKI develops filter clotting frequently despite being on anticoagulation. What is the next best step for this patient? A, increase blood flow rate. B, switch to intermittent hemodialysis. C, use regional citrate anticoagulation. D, stop anticoagulation. E, switch to peritoneal dialysis.
C.
Any attempt? Can you hear me?
C.
C. Who said C? Who said C? Why C? I want to know why you said C. Hello? Okay, C is correct. I just want to know the rationale behind your C. Number 4, a patient with multi-organ failure requires renal support. The ICU is low resource with no continuous renal replacement therapy machine available, and the patient is hemodynamically unstable. Which renal replacement therapy modality is a practical alternative? A, intermittent hemodialysis, B, SLED, C, peritoneal dialysis, D, conventional hemodialysis with high flow rates, E, no dialysis at all.
B.
Sorry?
B.
Mention it. I'm hearing B or C.
Low efficiency daily dialysis.
Correct. You guys know everything, so maybe there's no need for the lecture now. A 70-year-old patient with chronic kidney disease or maintenance hemodialysis is admitted with sepsis and hypotension. It requires renal replacement therapy in ICU. What factor influences the choice between CRRT and IHD most? A, patient's urine output. B, blood pressure and hemodynamic stability. C, patient's age. D, duration of dialysis before admission. E, presence of peripheral vascular disease. Which one will influence your choice?
B,
B.
blood pressure and hemodynamic.
Hemodynamic stability.
Beautiful. Good, good. Great job. All right. So, renal replacement therapy refers to interventions that replace the excretory, regulatory, and metabolic functions of the kidney in patients with severe acute kidney injury or patients with end-stage kidney disease. Like the name implies, renal replacement therapy. Any intervention that replaces the functions of the kidney. The aim of RRT is to remove waste products and excess fluid from the body, also to correct electrolytes like hyperkalemia and acid-based imbalances, especially severe metabolic acidosis that's refractory to other conventional measures. So RRT is classified according to the source, the mechanism of solute removal, either by filtration or by diffusion, or by the duration of the treatment. So let's look at how solutes are removed from the body by renal replacement therapy. Number one is by diffusion. All right, remember for chemistry, diffusion is the movement of solutes down their concentration gradient across its impermeable membrane. So from regions of high solute concentration to regions of low solute concentration. An electrochemical gradient is created using the flow path system with a toxin-free diazolate solution. So diffusion is applied in intermittent hemodialysis and peritoneal dialysis. All right, this is best suited for removal of small molecules like urea, creatinine, and potassium. All right, the other mechanism of solute removal in renal replacement therapy is what? Convection. All right, here solute removal is via what we know as the solvent drag, where the solute moves together with water across a porous membrane. All right, a transmembrane pressure is applied, producing an ultrafiltrate, which is later discarded and replaced with toxin-free replacement fluid. This is what is used in the hemofiltration and the continuous renal replacement therapy. Convention is useful for removing large molecules, all right, like the medium molecular weight toxins. All right, so let's look at the dialysis, the equipment for hemodialysis or dialysis itself. We have the dialysis machine. All right, this is what pumps blood through the extracorporeal circuit. It also monitors pressures, flow, temperature, and alarms for safety. It controls the flow of the dialysate and its composition. The second equipment is the dialyzer itself, which is the artificial kidney. All right, most are made of a hollow fiber, and they contain a semi-permeable membrane for diffusion and ultrafiltration, like we mentioned before. The other equipment for hemodialysis or dialysis is the blood lines and the extracorporeal circuit. All right, we have the arterial line which carries blood from patient to the dialyzer, the venous blood which returns clean blood to the patient. All right, there are drip chambers, air detectors, and pressure monitors. The dialysate system, all right, contains the water which is purified by reverse osmosis, which is mixed with acid and bicarbonate concentrate. All right, it has other composition as prescribed, the sodium, potassium, calcium, and bicarbonate. The other equipment is the vascular access, all right, which can be AV fistula, AV graft, or your central venous catheter using the dialysis catheter. All right, so this is an example of a dialysis machine that is labeled. From the left, we have the dialyzer. All right, this is where other diffusion or ultrafiltration takes place. The arterial line, which carries blood to the patient. All right, I mean, the venous carry blood to the patient. Why do we have the arterial line, which carry blood from the patient to the system? This is the dialysate concentrate, all right, which contains purified water and different components. Okay, this is the water supply, bicarbonate decided heparin. This is the blood pump that pumps blood to and fro the patient's blood system. We mentioned reverse osmosis, so I just felt we should just remind ourselves. All right, remember the osmosis, normal osmosis, water moves across the semi-permeable membrane from an area of low solute concentration to an area of high solute concentration. All right, but in reverse osmosis, an external pressure greater than the natural osmotic pressure is applied, which pushes water into the opposite direction. All right, that is from high solute concentration to low solute concentration. All right, so reverse osmosis is a water purification process. All right, where water is forced through its impermeable membrane, allowing water molecule to pass through, but blocks salts, impurities, bacteria, and all that, and larger molecules. The end result is purified water, all right, which is devoid of any form of impurities, salt, and bacteria. And this is the water that is used in dialysis. All right, so hemodialysis is the removal of solute and water from the body by diffusion across the semi-permeable membrane using an artificial dialyzer that we said earlier on. So the word dialysis actually from the Greek words dia and lysis. Dia means true and lysis meaning loosening or splitting. So you're splitting solute and water, all right, and pass it through a dialyzer. The key principles of hemodialysis is diffusion. Solutes move down their concentration gradients from high concentration region to low concentration region. All right, and the low concentration region is the toxin-free dialysate. All right, there's this countercurrent exchange system, all right, in which blood flows through the dialyzer at a slower rate of 200 to 300 ml per minute, while blood flow from the dialysate in the opposite direction, all right, at a greater flow rate, 500 and 800. The countercurrent system maximizes concentration gradients, improving clearance of waste products very significantly. Now, that hemodialysis is efficient in achieving solute clearance of an entire day of normal bleeding in just 3 to 5 hours. So the function of the kidney for a whole day, solute clearance for a kidney is done in 3 to 5 hours. Highly effective for small molecules removal like urea, creatinine, and potassium. Typically, hemodialysis is used in patients with chronic kidney disease as a maintenance dialysis, patients with acute kidney injury, all right, intermittent hemodialysis. This is where we come in, especially in the ICU setting. All right, certain poisons can also be removed by dialysis. Now, the limitation of hemodialysis are numerous, which includes the requirement for vascular access and the complications that arise from passing a dialysis catheter or getting an arteriovenous fistula. All right, hemodialysis is not ideal for patients, hemodynamically unstable patients. You can imagine a patient in septic shock, all right, requiring dialysis. All right, there's need for repeated sessions in order to support the patient, efficiently. So this is just the dialysate that we saw, all right, the dialyzer with the dialysate, which is a hollow fiber, all right, with the same permeable membrane. The blood flows through it. So the blood, this is the solutes, the waste product you want to remove has a higher concentration on the other side and moves through the same permeable membrane through the dialyzer into the diazolates, all right, which is later pumped back into the patient system. The diazolate consists of highly purified water, like we mentioned, which is gotten by reverse osmosis with sodium, potassium, magnesium, calcium, bicarbonate, chloride, and dextrose as prescribed, all right? The different diazolate has different composition. All right, recently we noticed that some of our patients in our ICU after dialysis, still retains a high serum potassium, and we had to reduce the potassium content of our diazolate. All right, so it lacks low molecular weight waste products, which is present in uremic blood. When it's permeable membrane separates uremic blood and diazolate, there's a flush rate of waste solutes from blood to diazolate exceeding the backflows from the diazolate blood. Ideally, this should get to a point where equilibrium is achieved. But during dialysis, a concentration equilibrium is prevented from forming, and the gradient is maintained by continuously refilling the fresh dialysis solution in the dialyzer and replacing dialyzed with undialyzed blood. So as long as dialysis for that rate of 5 hours is concerned, equilibrium between the blood and diazolate is never reached. So the other way of removing solutes, apart from dialysis, the hemodialysis is hemofiltration. All right, and this uses convection, like we mentioned before. So this removes solutes and water using a hydrostatic pressure gradient, where solute moves together with the solvent. All right, so the solvent drags the solute along with it. All right, this removes large fluid volumes, about 3 liters per hour, but at a slower solute removal rate compared to hemodialysis. It is more efficient at removing middle molecular weight solutes, unlike hemodialysis that removes smaller molecular weight solutes. All right, the key principles of hemofiltration, like we mentioned, is convection, where molecules less than 50,000 daltons are dragged along with the solvent across the impermeable membrane. All right, the end product is the filter, the ultrafiltrate, which is later discarded. Replacement fluid is added to the blood circuit, which is adjusted according to the desired fluid balance and electrolyte needs. All right, so vascular access for hemofiltration is either arteriovenous or venovenous access. All right, hemofiltration is commonly used in the continuous renal replacement therapy for hemodynamically unstable patients in ICU specifically, and for fluid overload with patient with AKI or patient with sepsis. Now, if you look at it, this is the blood. There's an application of positive hydrostatic pressure, which moves water and solute. Water is the solvent and moves solute with it, all right, into the diazolate, which forms the ultrafiltrate, which is later discarded. Then we have the third one, the hemodiafiltration, which combines hemodialysis and hemofiltration in a single session. So we have both diffusion and conversion taking place. All right, the key principle is that diffusion helps to remove small solutes effectively, while convention helps to remove medium molecular weight solutes via the solvent drag that we mentioned. All right, in hemodiafiltration, there's use of diazolate and replacement fluids to maximize solute clearance. The benefits of hemodiafiltration, number one, is that there's enhanced clearance of small solutes compared to hemofiltration alone. All right, it has a better medium molecular waste removal compared to hemodialysis alone. Remember that it's combining both dialysis and hemofiltration. Now, this will help to optimize fluid balance and metabolic control simultaneously. Okay, so it's often used in continuous renal replacement therapy in ICU patient, all right? And usually the vascular access the venovenous via central venous catheter. Then we have the slow continuous ultrafiltration. Slow continuous ultrafiltration. This is designed solely for fluid removal with minimal solute clearance. All right, so this is designed for fluid removal alone. All right, the key principle is through ultrafiltration via impermeable membrane. This is driven by low transmembrane pressure gradient. There's no need of diastolate and no need of replacement fluid here. The filtration rate is low, but it's very continuous and can remove up to 6 liters per day of fluid. Remember that there's minimal solute loss, primarily water is removed, so this is useful especially for cases of pulmonary edema or cerebral edema that you need to just remove excess fluid. All right, so management of, the usefulness of slow continuous ultrafiltration SCOF is management of refractory fluid overload in patients with congestive heart failure, oliguric AKI, and is specially suited for hemodynamically unstable patients. Vascular access is also venovenous, which is the most commonly used. All right, so the other classification of renal replacement is by the duration of solute removal. Duration of solute removal. So we have intermittent hemodialysis. All right, here high flow rate for a defined period of time, usually 3 to 5 hours and 3 times a week. Here patients are hemodynamically stable and is the basis for long-term renal replacement therapy. Because of most of our patients are hemodynamically unstable, intermittent hemodialysis is usually not recommended in the ICU. Disadvantages of intermittent hemodialysis IHD is IHD, all right? So intermittent hemodialysis has inferior uremic control. This is due to episodic solute removal, all right? You can cause increased intracranial pressure for rapid solute shifts. All right, IHD can also cause hypotension due to large volumes that are removed over a short period of time, which reduces venous return and cardiac output. Because of repeated hypotension that ensues, we have delayed renal recovery. So just remember the disadvantages of intermittent hemodialysis, IHD, is also IHD. All right, so the second one, duration of solute removal, is the continuous renal replacement therapy, CRRT. All right, so filtering of solute and or dialyzing on a continuous basis, usually initiated with a low flow of 100 ml per minute, and this can gradually be increased to 200 ml per minute of flow. All right, it is inherently complex and requires the use of anticoagulation, the use of high volume of fluid, and is also much costlier compared to intermittent hemodialysis. And that's why CRRT is usually not commonly available in our settings because of the high cost. But it's considered for patients with cerebral edema, severe hemodynamic instability, patients with persistent and refractory ongoing metabolic acidosis, and patients that require large fluid removal, all right, without causing hemodynamic instability. So we have different types of continuous renal replacement therapy. We have the slow continuous ultrafiltration, the continuous venovenous hemodialysis, continuous venovenous hemofiltration, and continuous venovenous hemodiafiltration. Then we have the continuous arteriovenous hemofiltration and SLED, the slow low efficiency daily dialysis. The advantages of CRRT is many, all right? Includes better fluid management, causing less hemodynamic instability, provides it has ability to provide protein-rich nutrition while achieving uremic control, better control of electrolyte balance, including phosphate and calcium, prevention of swings in intracerebral water, all right, reducing the potential for intracranial hypertension. There's minimal risk of infection, and it has a high level of biocompatibility. The significant disadvantage is more expensive, like we mentioned, and requires continuous anticoagulation. Okay, so the slow, low efficiency daily dialysis SLED is a hybrid renal replacement therapy that combines the advantage of intermittent hemodialysis and continuous renal replacement therapy. It is a prolonged dialysis session that usually performed daily, typically lasting 6 to 12 hours, using lower blood and diastolic flow rates. The purpose of using SLED is provision of gentle and efficient removal of solids and fluid in patients who are hemodynamically unstable, especially patients in ICU. It also minimizes rapid fluid and electrolyte shifts, all right, compared to conventional intermittent hemodialysis. All right, for you to remember SLED, just remember the mnemonic SLED. What are the key features of SLED? S, slower and gentler clearance rates compared to standard hemodialysis, but faster than CRRT. All right, it's usually for longer periods than the standard dialysis of 3 to 5 hours. All right, this one is usually 6 to 12 hours, and sometimes up to 12 hours, 24 hours rather. All right, it also uses lower blood flow, okay, about 100 to 200 ml per minute. It's efficient, E, and the diastolic flow is also low, all right, between 200 to 300 instead of 300 to 500 ml per liter. It's indicated in critically ill patients with AKI who are hemodynamically unstable, all right, for fluid overload requiring gradual removal, patients require renal support but cannot tolerate standard IHD. So what are the benefits? Also remember SLED. All right, stable hemodynamics is less resource intensive than CRRT, is efficient and provides improved metabolic and volume control. And remember that it does not require continuous anticoagulation, which is often needed in CRRT. The limitation of SLED includes a requirement for prolonged dialysis machine time and monitoring. So it can also be labor intensive and may not provide as continuous solute control as CRRT. Okay, so the other one is the peritoneal dialysis usually performed in low resource setting and pediatric patient. Yeah, so peritoneal dialysis is a form of renal replacement therapy that makes use of the patient's peritoneum as its impermeable membrane to remove waste products and excess fluid from the body. So the diastolate is instilled into the peritoneal cavity through a catheter, and solutes of water move across the peritoneal membrane by diffusion and osmosis from the patient's blood into the diastolate, which is later drained and replaced with fresh fluid. So there are two types of peritoneal dialysis. We have the continuous ambulatory peritoneal dialysis. This requires manual exchanges throughout the day. And we have the automated peritoneal dialysis where the machine performs exchanges overnight. So indications for peritoneal dialysis include patients with chronic kidney disease that requires dialysis, especially when vascular access is difficult or contraindicated. Patients, AKI patients, when other modalities of RRT is unavailable or contraindicated. hemodynamically unstable patients who may not tolerate hemodialysis, and pediatric population. The advantages of PD is that it does not require vascular access, is gentler, and has continuous fluid removal, and is better tolerated in unstable patients. Can be performed at home or low resource or resource limited settings. All right, so this is it. The diacylate is instilled into the patient's peritoneum, and solution with waste product is removed and replaced with fresh fluid. Now, the limitations and complications are obvious. The risk of peritonitis is less efficient, all right, compared to hemodialysis or CROT. It also requires patients training and compliance, but know that it's contraindicated in patients with abdominal adhesions or recent abdominal surgery. Okay, now, generally, what are the indications for renal replacement therapy? Okay, know that about 70% of patients with AKI will require RRT in one form or the other. So indications for renal replacement therapy, remember Father P. Sometimes I call it Father CP. Okay, this is my mnemonics. F stands for fluid overload, A, anuria or acidosis, which could be metabolic, usually pH less than 7.2. Toxemia, all right, or azotemia, when you have urea concentration of greater than 30 millimole and creatinine greater than 300 micromole per liter. All right, it's easy to remember this. When urea is more than 30 millimole per liter and creatinine is greater than 300 micromole per liter, okay? Patients with hyperkalemia, typically serum potassium greater than 6.5 millimole per liter. Patients with encephalitis or uremic encephalopathy, okay? Patients with refractory GI symptoms and patients with pericarditis, usually constrictive pericarditis. All right, the common indications that I'm sure most of us are aware of is the vowels A, E, I, O, U. Okay, but I preferred my own mnemonic is father because I think it's more, all right, it's more encompassing. But just for your information, so you can use the vowels A, E, I, O, U, where you have acid-base disorders, especially acidosis, electrolyte imbalance, usually referred to hyperkalemia, intoxications, all right, and overload, fluid overload that is usually unresponsive to the use of diuretics, patients who are uremic, all right, whether encephalopathic or uremic pericarditis or coagulopathy resulting from uremia. Okay, these are some of the complications, but let's look at these complications. You can look at the complications variedly and widely, looking at the access, okay, the respiratory, but let's just go to these mnemonics that I coined out. So complications of renal replacement therapy, all right, you can use hemodial, okay? Number one, it can lead to hemodynamic instability, which is mostly seen with intermittent hemodialysis, all right? But it can be regarded as a generic feature for renal replacement therapy. All right, H, hypothermia. Usually, the blood that is returned back to the patient through the blue catheter, usually cold. Hypoxia, all right, resulting from activation of complement and inflammatory mechanisms. All right, hypocapnia. Sometimes carbon dioxide will diffuse to the membrane and into the diazolate. All right, access complications, vascular access complications, which can lead to bleeding, vessel damage, bloodstream or localized infection, and you can actually introduce ear to cause ear embolism. So, in as much as RRT is useful in managing electrolyte disturbances, it can also predispose patients to electrolyte disturbances like the hypoelectrodynamic electronemia or electrolyte depletion. You can also have hyper due to removal of too much fluid. All right. Patients on hemodialysis or renal replacement therapy may be malnourished. Okay, this is due to dilated nutrient loss. All right. Sometimes dialysis removes many of the useful nutrient molecules. We have disequilibrium syndrome, all right, which is very common, especially for first-time patients undergoing dialysis, usually due to rapid and large movement of small solids that the concentration of the chronically accumulated uremic waste in the brain becomes substantially greater, leading to CNS symptoms. We can have inflammatory response and anemia, all right, due to hemolytic causes or due to blood loss during the vascular access maneuvering. So quickly, dialysis disequilibrium syndrome is characterized, all right, it's one of the common complications of RRT, and it's characterized by a range of neurological symptoms, all right, that affect patients on hemodialysis, particularly when they are first started on dialysis. Okay, sometimes it may be seen among patients who have missed multiple consecutive dialysis treatment. Note that it's rarely described in patients with continuous renal replacement therapy. This is another advantage of CRR routine. DDS develops primarily from an osmotic gradient that develops between the brain and the plasma as a result of rapid hemodialysis. All right, this results in brain edema that manifests, all right, as headache, nausea, vomiting, and all of that. Know that patient can die actually from disequilibrium syndrome because of advanced cerebral edema. What are the etiological risk factors for disequilibrium syndrome? All right. Forced dialysis treatment. Okay, when you have high blood urea ratio, blood urea nitrogen above 175 milligram per dl or 16 millimole per liter before initiating dialysis. Extremes of age, children and elderly are more prone to DDS. When you have sudden change in the dialysis regimen, all right, pre-existing neurological diseases such as stroke, malignant hypertension, head trauma, or seizure disorder. Presence of other conditions that can cause cerebral edema, all right, like your hyponatremia or patients with hepatic encephalopathy. Other conditions causing increased permeability of the BBB, the blood-brain barrier, for instance, sepsis, meningitis, and what have you. So how do you manage? All right, the teaching is prevention is better than cure. So slow, gentle initial dialysis, okay? High sodium diacylate, also known as sodium profiling. Administration of osmotically active substances, all right, to reduce the incidence of cerebral edema. You may want to use mannitol or your 3% hypertonic saline. Now, if the patient develops seizures, all right, during dialysis, the first thing you need to do is to discontinue the treatment until seizure and other vital signs has been stabilized. Deployment of anti-epileptic drugs not cleared by dialysis are useful to control seizures in this group of patients. Okay, the idea is not to make you a nephrologist, but as an intensivist or anesthesiologist training, you need to familiarize yourself with how dialysis is set up. Okay, so the following slides will just give you step-by-step a setting up of your dialysis. Okay, so the first one is preparation. All right, you want to verify the prescription order, all right, in conjunction with your nephrologist. So number one is what kind of modality, what modality of dialysis is best for this patient? Are you using hemodialysis or hemodiafiltration or SLED? All right, you also want to confirm the duration for how long For hemodialysis, 3 to 5 hours. For SLED, you may want to use 6 to 12 hours. You want to confirm the blood flow rate, the dialysis flow rate, ultrafiltration goal, and if you're going to use anticoagulation. Then you want to check your dialysis machine in terms of power supply, water supply, and availability of concentrate. Ensure infection control measures, hand hygiene, and your personal protective equipment. You want to gather your supply, the dialyzer, your blood lines, the dialysate concentrate, the priming saline, heparin, if you're using it, syringe and needles, all of this you want to verify. All right, so step 2, you want to inspect your machine and disinfection. So the first thing, you want to switch on your machine and allow the machine to perform a self-diagnostic check, just like your anesthetic machine. Okay, you want to run the recommended disinfection cycle before use, either chemical or heat disinfection as indicated. Okay, you want to check your alarms and safety system, ensure your blood leak detector is in place, air detector to reduce the risk of air embolism. Venous pressure monitoring must also be checked for functionality. Okay, so the step 3, connect to water treatment system, ensure that treated water from your reverse osmosis is available, and you attach your dialysate concentrates, those jerry cans of solutions we saw earlier on, containing acid solution of bicarbonate cartridge or container. So select your dialysate composition, how much of sodium, potassium do you need as per the prescription. So install the dialyzer, all right, that is the artificial kidney, and secure it in place with arterial and venous ends correctly oriented. Okay, you want to collect your blood line. The red line is the arterial line connected to the arterial port of the dialyzer, and the blue, the venous, you must connect it to the venous port of the dialyzer. So connect the dialysate hoses, the dialysate inlet and outlet lines to the dialyzer's corresponding ports. Priming, you want to prime the extracorporeal circuit, either with normal saline to flush the dialyzer and the blood lines, and also to remove air and disinfectant residues. You want to check for air bubbles, inspect visually, and tap air traps to dislodge micro bubbles. Prime heparin line if used, okay? And what you do this is to flush with saline to prevent clotting before you connect the machine to the patient. Okay, machine programming, enter the patient's ID, the weight, the target weight, and the UF goal, that's the ultrafiltration goal. Then select treatment parameters, including the blood flow rate, the dialysate flow rate, the treatment duration, and temperature. Remember that we did say one of the complications of dialysis is hypothermia. Right? Select anticoagulation mode with heparin loading and the maintenance doses, or patients who have fetal clotting, you want to use regional citrate as indicated. Safety checks, verify alarm function, ensure saline bag, all right, for priming and possible rinse back, and inspect your lines, your blood lines for kinks and leaks. All right, prepare your vascular access. Most times we usually put the dialysis catheter, central catheter, all right, and connect arterial line to access arterial plot and all that, okay? So monitor during treatment, all right? Once your patient, you've started treatment, you want to monitor, and remember that the dialysis machines also has a multi-parameter mode where you can monitor the blood pressure, heart rate. You should monitor the access site, venous and arterial pressure, your ultrafiltration rate, conductivity, and patient's temperature. So if you are asked, what are the parameters that you must monitor during dialysis? These are some of them, 6 of them. Okay, termination. At the end, when you have achieved your dialysis goal, you want to return blood to the patient, all right, using saline rinse, then disconnect the patient, remove needles, catheter connections, and make sure you achieve hemostasis, all right, dispose of every single-use items, by following biohazard waste protocol as per your unit protocol. You want to disinfect your machine to get it ready for the next patient and run end of day disinfection by policy. Okay, so this is just an info diagram of how to set up dialysis machine. Okay, so these are some of the studies that I brought in here. I hope it's not too small because I didn't want to have too many slides. Now, what is the association between furosemide administration and outcomes of critically ill patients who have AKI? All right, this study was actually aimed at looking at, the association between the use of furosemide and outcomes in patients with AKI using real-world data. Okay, and critically ill patients with AKI were identified from the media information map for ICU database, and a total of 14,154 AKI patients were included in the data analysis. All right. And they found out that furosemide was actually associated with reduced in-hospital mortality. Okay. And also was also associated with recovery of renal function. All right. In over all AKI patients. Nevertheless, the result shows that furosemide was not associated with reduced in-hospital mortality in patients with cardiac stage 0 to 1, okay? And in those with acute or chronic renal injury. So the study concluded that furosemide administration was associated with improved short-term survival and recovery of renal function in critically ill patients with AKI. So it was also said that furosemide was especially effective in patients with AKI stage 2 to 3 degree. However, it was not effective in those with AKI with serum creatinine stage 2 to 3 and chronic disease patient. Okay, so this is this study that looked at the use of furosemide in patients with AKI in the ICU. All right, continuous versus intermittent use of furosemide in patients with heart failure and moderate chronic renal dysfunction. So the study aimed to compare the efficacy and safety of continuous and intermittent venous furosemide administration. Okay, and the study concluded that continuous intravenous infusion of furosemide resulted in significantly greater diuresis than bolus administration of equal dose. Okay, with no differences emerged in terms of side effects or mortality. So in ICU, most of the times I prefer continuous use of furosemide, maybe 2 milligrams per hour, all right, as a continuous infusion because it leads to sustained diuresis, especially in patients with oliguric AKI. So what are the potential roles of furosemide in patients at risk of AKI? Okay, as part of strategy to avoid fluid retention in patients with coexisting AKI, acute lung injury, all right, the ARDS network protective ventilation strategies, all right, it's found out that furosemide can actually reduce the duration of mechanical ventilation and length of stay in the ICU, okay? And urinary response to furosemide acted as a prognostic test to predict the risk of requiring renal replacement therapy. Also, it found that concurrent use of furosemide with ultra-tight improves glomerular filtration rate, urine output, and portal hypertension in patients with portal hypertension and ascites. Okay, as part of therapy with hydration and biphosphonates for hyperglycemia, furosemide has found a useful use. Okay, furosemide with 0.9% saline is better than 0.9% saline with mannitol in preventing cisplatin-induced nephrotoxicity. Furosemide also has found useful role in the control of hyperkalemia and acidosis in patients with hyperkalemic renal tubular acidosis, which is common in early stage of diabetic nephropathy. All right, I think we should conclude there because of time. So early diagnosis and prompt intervention prevents fatal outcome in 8KI, especially with early institution of renal replacement therapy. In multi-organ failure, remember that the kidney is the first to fail, all right, and the first to recover in the instances of multi-organ failure. All right, these are some of the references. Thank you. I hope I've not bored you. I hope you all followed. Did I bore you with my long lecture today?
No, it was well delivered. Thank you, Prof.
No, Prof. It was
Okay.
great.
Did you follow?